Hello and welcome to the session on pain and work disability. My name is Doug Gross. I'm a professor in the Department of Physical Therapy at the University of Alberta. I am a physical therapist by background, graduating in 1997. I've worked clinically in various orthopedic and private practice physical therapy centers and also in occupational rehabilitation centers. But for the last 25 years, I've led a research program around work disability prevention. So today I'm going to be talking about some of what we've learned, some of the evidence around work disability prevention and return to work in painful conditions. Pain is some of the leading, pain-related disorders are some of the leading causes of work disability. Low back pain, shoulder pain, neck pain. These are very common work-related pain conditions. And as I said, they're leading reasons for why people go off work. So I would like to start by saying that the University of Alberta is primarily located on the traditional territory of the Cree, Blackfoot, Métis, Nakota, Sioux, Iroquois, Dene, and Ojibwe, Saulteaux, and Anishinaabe nations. Basically, Treaty 6 is where I'm at today, Edmonton, Alberta, and homeland of the Métis. The University of Alberta respects the sovereignty, lands, histories, languages, knowledge systems, and cultures of First Nation, Métis, and Inuit nations. I also would like to share financial disclosure. As I said, I've been leading a research program, and so the bulk of this are operating grants, research grants that I've received from various national and provincial organizations. I have received some speakers honoraria to travel and speak on this topic to various conferences and to various organizations. No consulting fees. I am a full-time employee of the University of Alberta. I am actually the chair of the Department of Physical Therapy, in full disclosure at this point. I'm also the editor-in-chief of the Journal of Occupational Rehabilitation, and I receive a small stipend annually from Springer. All right, work. Let's talk about work. Work is one of these four-letter words that we have kind of conflicting thoughts, conflicting emotions, conflicting opinions around. We love it or we hate it. Here's a couple of quotes that kind of speak to this. Life is too short to work so hard, from Vivian Leigh, an Oscar award-winning actor. Also, there is no substitute for hard work, from Thomas Edison. This kind of shows the conflicting viewpoints around work. We recognize the value of work and allows us to get things done, and yet we try to avoid it at all costs and celebrate our kind of personal time. One big question, though, regardless of what you think about work, is how does work affect our health? Is work good for your health and well-being? This is a question that was tackled by Gordon Waddell and Kim Burton. These are two people who I'm sure those of you in the pain world know or recognize the names. Gordon Waddell was a orthopedic surgeon from Scotland who, I wouldn't say that he gave up on orthopedic surgery, but he got to the point where he recognized that not every orthopedic condition could be solved or cured by surgery. And so for many years, many decades in fact, he dedicated his life to doing research around other ways, other strategies, other interventions to help people cope and manage with pain-related conditions. Kim Burton, very similar. Kim, though, is ergonomist by background, and so kind of brings a slightly different work-related perspective to this question. I think it was about 20 years ago now, the British government, the government of the United Kingdom, funded these two to do a systematic review and a comprehensive search of literature and research and evidence answering this question. They wrote basically a full book. It's downloadable. I'll include this in the reference list. Basically, they were able to itemize and list the many benefits of work. Work is central to our identity and our social roles, who we are as individuals. And this is not just paid work. This is volunteer work. This is unpaid work, work in the home, work in the community. But whatever we do for work or occupation becomes central to who we are. Therefore, work meets many of our psychosocial needs, gives us a sense of meaning and purpose. And really importantly, they found evidence that work provides income, and income is associated with health. Employment and socioeconomic status are primary drivers of gradients in health. Basically, the wealthier you are, the healthier you are. And this, they found that it applied at the individual level and at the national level, internationally, when you look at this. So many benefits of work. There's also many adverse effects of long-term work loss, being off work for a prolonged period of time. Although they also recognize and appreciate, or were able to highlight, that there are risks associated with work. It can cause health conditions or associated with many health conditions, including pain. So in answer to the question of, is work good for the health, they concluded that the beneficial effects of, and I've added in here, safe and meaningful work on physical and mental health generally outweigh the risks of work and the harmful effects of long-term unemployment. And this applies even to those who are sick or disabled, even to those with chronic pain. But what about pain at work? Almost everyone has experienced one type of pain or another at work, either associated with work duties, caused by work duties, or exacerbated or inflamed by work duties. Many times pain interferes with our ability to do what we need to do. Sometimes what we're doing actually is the causal source of our pain. We might lift or carry or twist the wrong way at our workstation and experience that pain. One of the things that literature has shown that the common prevailing conceptualization of pain at work might be incorrect. Typically, when we pick something up at work, experience a bout of back pain, we've thought of that as an injury. We have whole insurance systems, workers' compensation systems dedicated to handling and managing work-related injuries suffered in the course of work. We would, file a claim, a workers' compensation claim for low back pain. That's considered an injury. It may or may not be accepted. If it is, you then are covered with wage replacement benefits, healthcare services to help you do what you need to do to be able to return to work after recovering from that injury. Unfortunately, we know that this prevailing conceptualization is not always true. I mean, sometimes it is as simple as an injury occurs at work, fractured arm, it's painful, you need a period of convalescence and recovery, and you're able to then return to work. This is at the heart of the medical or injury model, the illness model of disability. But like I said, it doesn't always hold true. We know that the realities of pain are that it's not always linear like this. Sometimes it can come and go, leave for a period of time and then come back. It's episodic, it's fluctuating. We know that the recovery process in many painful conditions is unpredictable. We know that many times it's nonspecific and there's nothing that can be seen on an X-ray or an MRI or a CT scan. So it becomes an invisible disability, nonspecific condition. We also know that pain and disability because of pain has multiple interacting influences. I'm sure in this course, you've talked about biopsychosocial influences on pain. Well, I'm here to talk about other social and broader contextual and cultural influences on pain. This episodic nature of pain has been observed for many years. One of the places where it was very evident in my own research was a paper that we did published in Pain in 2011, Workers' Perspectives on Low Back Pain Recurrence. And then this quote in the title that came from one of our participants. This was a qualitative study looking at workers' understandings of recurrent pain. We know that things like workers' compensation claims can be recurrent, they can be closed, they can be reopened. And that's like, it has a strict definition from an insurance or a workers' compensation perspective. We wanted to know what the workers thought of this. And it was pretty clear right from the beginning that they didn't agree with that. And in fact, they didn't really understand what we meant by the word recurrence. Here's a quote that kind of speaks to that. It's a constant. It's always there. And it's a reoccurrence. It comes and goes and comes and goes, but it's always there. Even the anxiety of it is always there. Many of these participants talked about how their pain, even if they weren't experiencing it at the time, changed the way that they performed activities. Sometimes they were guarded, or they were stiffer, or they would not lift something. They would ask for help. And even this anxiety of the pain influenced their work abilities, their work tasks, and how they approached work. This was an interesting opportunity for our research team because we were able to pick the issue cover. Amanda Young from Liberty Mutual Research Institute for Safety, which has since been disbanded, picked this painting by Mark Halpin. She thought it perfectly represented the individual workers, and their pain represented here as a shadow that it was kind of always following them around. It was always with them. Sometimes the sun would come out and the shadow would be brighter or darker. Sometimes the sun would go behind clouds and the shadow would dissipate, almost to the point of not being able to see it, but it was always there. So if the injury model doesn't hold true in most cases, what are some other alternatives? I put a paper in the citation list that has reviewed many of the available work disability prevention models. One of the most common and I would say useful models around now was created by Patrick Loisel and colleagues, called the Arena of Work Disability Prevention. Here it's represented as an ellipse. You can pause and take a look at this model, look at the various components of it. I would want to highlight that at the very center is the worker with the work disability. So this model has the worker at the center. Everything revolves around them. You can see that around this worker are various systems, multiple interacting systems, the workplace system, healthcare systems, legislative insurance systems, which are society's safety net, as well as personal coping strategies. So it does move, I would say, beyond a biopsychosocial model into more of a socio-ecological model. Around the entire outside of this model, you see the overall societal context. So things like societal, cultural, and political influences are taken into consideration. Another thing that's really important from any healthcare perspective, but especially with pain, is that this model is diagnostically agnostic. It was designed to apply to any painful condition, any health condition that might lead to interference with workability. So it doesn't matter if it's back pain, fractured limb, dislocation, any pain-related disorder, this model was designed. I want to talk for a little while about the healthcare system side of that model. As I said, I'm trained as a physical therapist, and so when I went through my physical therapy training, I was taught a lot of different modalities, exercises, different approaches for helping people cope with pain or treating pain. So I was very excited about going out and using these in the clinic. I would say that the outcomes were somewhat mixed, and I did not always achieve the outcome that I wanted to. Things like return to function, return to work. Quite often I was able to relieve pain, but I was not able to always help people return to work. This is really obviously demonstrated in a study that was published around 2005, Management of Work-Related Low Back Pain, Population-Based Survey of Physical Therapists. These researchers did just that. They surveyed PTs. They asked them about the goals that were being set, the objectives that they set with patients, the treatments that were being used, and the outcomes that were achieved. Here is a slide right from the paper talking about objectives, primary objectives. You can see this is divided into two columns. Number of patients with radiating pain, 190. Number with no radiating pain, 190. And those with radiating pain, 139. And this is percentages of cases in which this goal was set. By far, the number one objective was decreasing pain. Over 80%, over 90% in the case of radiating pain. There was a goal or an objective set to help relieve pain. Then you can see with decreasing frequency, the other goals: increasing range of motion, increasing strength, decreasing muscle tension, increasing endurance, educating the patient, and then finally, the very bottom there, improving function, increasing activities of daily living or work, returning to work. So an objective around return to work was set only in around 1 in 5 cases. That's not surprising then, that when you look at the goals on the outside, on the other side of the physical therapy intervention, there was high pain relief success. Over 75% of cases did achieve that goal of decreasing pain. However, less than 50% experienced return to work success. So this is just another reminder that only treating pain and offering pain relieving treatments is not going to guarantee return to work. Interventions, therefore, offered through the healthcare system, if we hope to achieve return to work, return to function, we need to specifically target return to work. And that's a real fundamental mindset shift from what I was taught in physical therapy school. And it leads us to use different kinds of approaches, different kinds of treatment techniques in our clinical interactions. One of those different treatment techniques is integrated care, workplace integrated care. This again grew out of Patrick Loisel's group, who developed that arena of work disability model. The arena was the theory that they were working on. The Sherbrooke model was putting that in, like operationalizing that theory. Patrick Loisel, a lot like Gordon Waddell, was an orthopedic surgeon. I would say I'm pretty confident. I got to know Patrick better than Gordon, and Patrick was quite disgruntled with orthopedic surgery. He thought it was overused, and he thought it didn't achieve the goal of return to function and return to work as often as it should have. He knew that there was other support, and he built around himself a team of allied health professionals, occupational therapists, physical therapists, sociologists, psychologists, other people within this healthcare system to help achieve that return to work goal. And he developed the Sherbrooke model that looks like this. So it's kind of a linear model. You can see the picture there talks about integrated care or participatory ergonomics. Integrated care, what he meant by that was, for one, integrated across these team members, but most importantly, including the workplace as one of those team members. Integrated the care, integrating the treatment at the workplace. Participatory ergonomics is a little bit different than traditional ergonomics in that instead of like a top-down directive telling the patient in the workplace what needs to be done, it's like bottom-up. There's a lot of consultation, discussing with patients, discussing with the workers, discussing with supervisors and managers, and brainstorming. What are the challenges at work? What do the workers have difficulty with? What might be causing the pain? Is there a way that this could be done differently despite the pain? Could we modify it? Could we create accommodated ways of doing the same task? Anyway, that's on the left side. On the right side shows this linear model. It begins with detection of cases at risk of chronicity at about the 4th week of absence from work. So it assumes that most people experiencing pain from work are going to recover. Most people's pain will go away. They'll have no difficulty and they will return to work quite rapidly. In fact, 80 to 90% of the time, there is just that, spontaneous recovery and return to work. However, if the individual is still off work by 4 weeks and there's yellow flags or other indicators that the individual is at risk of chronicity, then the model kicks in. 3-step process. Step 1 is an occupational intervention. Worker's visits to an occupational physician. So the worker will be referred to an occupational physician, and there will be a participatory ergonomics intervention done at the workplace. That's weeks 6 through 10 after absence from work. Step 2 If the occupational intervention didn't work, then there becomes a clinical intervention. The individual, the worker, is referred to a back pain specialist, possibly to a back school. There's education provided. If that doesn't work, then by week 13, early rehabilitation. I mean, this was from the 1990s, so nowadays we think that 13 weeks is not that early, but he called it early rehabilitation. This included functional rehabilitation therapy, graded activity, graded exercise, quota-based activity progression, a lot of work simulation, therapeutic return to work built into that. So there was some of the rehabilitation that would take place at a clinic, but as much as possible and as quickly as possible, a therapeutic return to work was began. A transitional return to work, maybe some of those modified duties, expanding further on that occupational intervention that was given earlier. So this is the model. This was evaluated in a few studies, and it was demonstrated by Patrick and his team that it led to both health benefits and economic benefits. The health benefit was improved function and more rapid return to work. Here we see scores from one of their papers looking at functional status as measured by the Oswestry Low Back Pain Disability Questionnaire. You can see at baseline, blue is standard care, red was a group referred only to clinical intervention, green received only the occupational intervention, and purple received everything, all of these, into that integrated model. Baseline, all very similar. 1 year later, you can see that there's improvement in all, but the Sherbrooke model resulted in the most improved self-reported functional status. On this side, you see rate ratio, basically a mathematical model, a statistical model looking at return to regular work, time to return to work, and you can see again that the Sherbrooke model helped these individuals return to work much quicker than any. The second quickest was occupational, clinical care only. The weakest was the standard care as usual. Patrick and his team also did a cost-benefit analysis, and they found that the Sherbrooke model led to a savings of just under $2,000 Canadian per worker in that first year. And again, this is $2,000, 1997 dollars. So it was quite cost beneficial, economic benefit, and health benefit. This was repeated by Han Anema, an occupational physician in the Netherlands, and his team. I had a PhD student, Ludeke Lambeek, who repeated testing of the Sherbrooke model in a Dutch cohort. Their randomized controlled trial of integrated care was published in the British Medical Journal. They found very similar results. They found that this integrated care substantially reduced disability in both private and working life, so health and occupational function and ability. For a small but relevant group of patients with chronic low back pain, again, they found that pain and work disability were treatment goals, and they found that not everyone who was able to return to work following this intervention had their pain fully relieved. In fact, they found that earlier resumption of work activities had no beneficial or adverse effect on pain intensity. They followed this up with a cost-benefit analysis, and they found that for every pound, this is British Medical Journal, so this is speaking in pounds, for every pound invested in the integrated care approach, it returned 26 pounds. I converted this into Canadian dollars. Basically, $1 Canadian returned about $53. So quite economically cost-effective. A very similar model again was tested in the Netherlands, although this was in the context of vocational rehabilitation for patients with chronic musculoskeletal pain. It was a little bit broader, not only back pain. This was Michael Renneman and colleagues, and again, they did an economic evaluation. I would say that the model that they were testing here was more that work model, very similar to the Sherbrooke model, but The work model tested by Michael Renneman was 10 contact hours. This was 10 hours either with a return to work coordinator, with case management, time spent developing a return to work plan, conducting a workplace visit, doing the participatory ergonomics again, mapping out a specific plan that is safe and tolerable for the worker. The study again showed both health and economic benefit. I've put the full citation in the reference list. They observed a mean cost savings of 820 euros for 0.012 QALY gained. So there's both improved quality of life and reduced cost for that. 38% return on investment. Okay, so I've talked about how pain and return to function or return to work need to be different treatment goals. I've talked about how we can do different things to achieve these different goals. I've talked about how specifically, if you're looking to help people return to work, you need to integrate healthcare at the workplace and do work-related interventions. But let's move a little bit into these clinical interventions, things that are done in the clinic by in this case, it's physical therapists or rehabilitation professionals. Rehabilitation is, for the most part, an in-person activity. People come in, they might be doing exercises, there might be some hands-on treatment by a therapist or other provider. One big question that arose and was really highlighted during the pandemic is, do we need this? Do we need treatment in the clinic? Can we do a lot of this at the workplace? Or can we do this even in a very creative way through telerehabilitation, allowing people to do it from home? So this is something that I've studied for several years, especially during the pandemic, but even pre-pandemic. I did a few studies looking at more conversational approaches to rehabilitation. We studied functional interviewing as a replacement for functional capacity evaluation, performance-based functional capacity evaluation. We've studied motivational interviewing in the context of occupational rehab. We've studied therapeutic relationship in the formation of therapeutic alliance with patients to see how that can be modified to improve outcomes. I would say that all of these are deliberate and patient-centered forms of communication, of dialogue. And consistently, my team found that these were as effective or synergistic with the more physical strategies, the in-person strategies. We found that the conversational approaches, especially with functional interviewing, led to lower risk of pain exacerbation, lower chance of flare-up if you're talking about what you can do versus lifting crates in a clinic. And we've also found, especially in the case of motivational interviewing, that applying these conversational rehab approaches lead to more sustainable return to work. I've put a couple of studies in the reference list if you want more details around this. But when the pandemic hit, we had done these various studies on conversational rehab approaches. And it was an interesting opportunity to see if these could be applied into telerehabilitation. So can occupational rehab be done at home? Can it be done through things like Zoom? Interacting with patients in the context of their own home to walk them through a workability assessment, to walk them through an exercise program, walk them through an occupational rehabilitation program. And we found, short story, long story short, that it can be done. We found in the early stages of the pandemic, we were able to have clinicians trained and apply functional interviewing rather than functional capacity evaluation and achieve the same outcomes in terms of sustainable return to work. We were able to see them conduct full occupational rehabilitation programs at home via telehealth, very creatively, but it was possible. And in the early days, we were more concerned about safety, about risks, about risk of exacerbation, about maybe something untoward happening at home. We found that it was quite safe. The second study at the bottom of the slide here was more of a long-term follow-up, 1 year later. And we found that there were no differences, either historically or after the pandemic, between occupational rehabilitation programs that were offered virtually through telehealth, in person at clinics, or via hybrid, which was kind of a combination of in-person assessment to begin with, follow-up via telehealth. We found that each of these modes were able to achieve comparable return-to-work outcomes. In addition to that, there's many other benefits of implementing virtual rehab services or telerehabilitation. This helps to overcome some of the barriers to in-person care. We have improved access to services, especially to those people in remote or rural locations. We see increased clinical productivity. We see reduced cost, both at the clinics, but also to the patients themselves, to the workers. They don't have to travel, sometimes hours to get to the clinic. They don't have to pay for parking. They love that. We've done some qualitative interviewing, asking patients what they like about virtual rehab. And probably the number one most commonly mentioned was that they don't have to pay for parking. Also time savings and improved collaboration and communication. So that brings us to the end of this session. A few take-home messages for you. Safe and meaningful work is generally good for the health. And as healthcare providers, we should be doing all that we can to help individuals who are off work because of a health condition, especially pain, to return to work safely and sustainably. But not all treatments aimed at reducing pain lead to return to work. So these pain-relieving modalities, they don't always guarantee return to work. You can help people cope with their pain, you can reduce pain temporarily, but there needs to be interventions targeting return to work specifically. These have been found to lead to both health and economic benefits, more rapid return to work. Lastly, there are some promising and cost-effective strategies to help promote return to work among people with a variety of pain conditions, integrated care, treatment at the workplace, and telerehabilitation. Thank you very much. There's the references that you can pause and take a look at on your own.